Can you please confirm that you can hear me? Great. Okay, so let's go and finish up hematology. If I'm not mistaken, the last thing we spoke about, was it hairy cell leukemia, or did we start with these guys? Did we finish leukemias, yes or no? Okay, excellent. Just a quick overview. Anytime that we have yes, yeah, okay, excellent. But I finished this page. Okay. So yeah, leukemias only. Yes, I see. I see. So I wanna make an overview on the leukemias. Just a quick notes. First note, I would like you to know that anytime a tumor tests positive for TDT, it means it's either it means that it's from a lymphoid origin, right? Anytime a tumor stains positive for myelofibrosis, it means it's from a myeloid origin. Okay, so again, TDT, that means it can be either a CLL or ALL. But if it was myelofibrosis positive, it can be AML or CML. The only tumor that has basophils on the periphery will be CML. One more thing, the one with the dry tap on the periphery will be either hairy cell leukemia or myelofibrosis. Also, the CLL has as much cells because the lymphocyte is super big that when we do the preparation, it gets smudged and destroyed, that create the smudged cells. For hairy cell leukemia, we use cladribine and bitostatin, which inhibit the adenosine deaminase, which increase the amount of adenosine, which is lymphotoxic. Remember that it is a TRAb-positive type of leukemia. For CML, we can use amitinib, which is a tyrosine kinase inhibitor. MBO is myelofibrosis. So, amitinib binds to the tyrosine kinase, which leads to its inhibition, which basically means there will be less proliferation and thus less tumor cells formation. Now we are going to move on with something known as Proliferative Neoplasias. And it's basically a malignant hematopoietic neoplasm with varying impact on the white blood cells and myeloid cell lineage. Remember, all of the cells come from the primary stem cell of the blood, which is known as the CD34 positive cell, right? And we have the following diseases here. So the myeloproliferative neoplasms include Polycythemia Vera, essential thrombocythemia, and myelofibrosis. Also CML, but CML is actually a leukemia, so it goes under both of them. What I want you to know that the first three that we discussed, all of them are JAK2 positive, Jackiestad system that I will explain later. But the SMLE is not. So, starting with Polycythemia Vera. Can somebody tell me, in Polycythemia Vera, since we have so much RBCs, what is going to happen to the viscosity of the blood? The viscosity of the blood. Yes, we will have increased viscosity of the blood. And increase in the viscosity of the blood, which liver disorder it can lead to? Liver problem. Budd-Chiari syndrome, absolutely correct. And in case of Budd-Chiari syndrome, which vein is affected? Is it hepatic vein or portal vein? Excellent, it's actually the hepatic vein. Will we have hepatomegaly in that condition? Yes, absolutely correct. So primary polycythemia, a disorder of increased RBCs, usually due to an acquired JAK2 mutation. So what is the JAK mutation? It's associated with something known as the Jackiestad pathway, okay? So this Jackiestad pathway goes something like this. Just a momento. Yes. You don't have to know the whole pathway, but you just need to know the general idea. So as you can see, there is a receptor, for example, erythropoietin binds to it, right? And now the JAK is, this is the JAK, right? And the JAK is going to be stimulating the STAT. The STAT is an inner signal molecule that can be moving, and when it gets phosphorylated, it means basically activated. And when the STAT gets phosphorylated and activated, it can go to an exact gene inside of our genome, which can lead to gene proliferation, okay? So the JAK phosphorylates the STAT, which leads it to translocate into the nucleus. And inside of the nucleus, it's going to lead to its activation of the gene expression. So let me send you this. So, yeah, it may present as an intense itching after shower, an aquagenic pruritus. There is a few things you have to know about aquagenic pruritus actually. Not only aquagenic pruritus, to be fair. There is other condition associated with shower. That's what I wanted you to know. So the other condition that is associated with showering is a person who get an intense abdominal pain after taking a shower. Any idea? Anybody knows why a person might get really severe abdominal pain after hot shower? Which problemo he has? Okay, I know this is difficult because it's nothing we spoke about before. We'll speak about it in psychiatry. It's basically cannabis. You know what is cannabis? A person who has a cannabis, basically a chronic usage of cannabis, okay, and has a cannabis toxicity, when he take a shower with hot water, he gets a severe abdominal pain. So if a patient comes to you with this presentation, ask him, do you smoke weed? If the answer is yes, associated with that. Okay, next question, weed. What can weed lead, weed, which is cannabis. Which main psychiatric problem can cannabis lead to? Psychosis and schizophrenia, absolutely. Teens who smoke weed during their teenage period are at highest risk of schizophrenia than those who don't, okay? I'm not saying that schizophrenia is only caused because of this, but it's associated. So the next thing they write, rare but classic symptoms is erythromyalgia, which is a severe burning pain and red-blue coloration of the skin due to an episodic blood clot formation in the vessels of the extremity. And the reason this happens basically is because of the hyperviscosity state of these patients. It's because of the hyperviscosity state they can get this erythromalacia. Okay, so mela in Latin means extremity. Okay, algia means pain. Erythro means red. So it's a red, painful extremity. Okay, erythromelalgia, red, painful extremity. Okay, so these patients with Polycythemia Vera, the receptor of the erythropoietin is hyperactivated because of the Jackiestad mutation. So it's internally hyperactive. But in reality, the EPO who normally bind to the receptor is inactive. It's going down actually. Why? Because it's a feedback mechanism, right? Basically, the EPO is innocent from the increase of the RBCs in case of primary polycythemia vera, because it's just a failure of the secondary messenger. So versus secondary polycythemia, which present with endogenous or artificial increase in EPO. Keep in mind that some patient can have a, do the doping, which means they inject themselves with EPO to get high performance. These patients will have high EPO and high RBCs. So how do we treat it? With phlebotomy, which is basically bloodletting, hydroxyurea, and basically roluxitinib. I keep forgetting about this drug. But basically it inhibits the Jackiestad pathway, which is going to decrease the amount of the RBCs. Guys, anytime you hear a monoclonal antibody, think about this sign, okay? They are really expensive, and really just a few people are really lucky to be able to utilize these medication. Essential thrombocythemia is characterized by a massive proliferation of megakaryocyte and platelets. Remember, platelets are basically the fragments of a megakaryocyte, right? Just the fragments of the megakaryocyte. So symptoms include bleeding and thrombosis. Blood smear will have a markedly increased platelet, which may be large or otherwise abnormally formed as this. Look, this platelet is huge. A platelet normally should be much smaller than the RBCs, but here the platelet is huge, which is characteristic of essential thrombocythemia. Which other disease have really big platelet? I told you about one disease that had a massive platelet, but in that disease we had something different. What was the name of the disease? No, that was not CML. I told you about no, that was not Henschenlon. A disease with really big size platelet, big platelet. I hope you remember about something called the Bernard-Soulier. I told you big suckers, so big platelet, right? Big suckers. So Bernard-Soulier will also have that. But in Bernard-Soulier, we will not have a thrombocytosis, basically. We will not have an increased number of thrombocytes. Okay, so in this patient also erythromyalgia can occur. Again, erythro means red, algia means painful, mela means extremity. So it's a painful red extremity. So the next thing we have is myelofibrosis. Myelofibrosis, which is a typical megakaryocyte hyperplasia. Well, megakaryocytes are normally where? In the bone marrow, right? So there will be a lot of TGF-beta secretion. Remember the function of these guys inside of the liver? Anybody remember? What they led in the liver? And they led to activation of which cell in the liver? Come on, liver. So, no, not hepatocyte. The TGF-beta, yes, the fibroblasts. So the TGF-beta used to stimulate the stellate cells, right? And the stellate cells or eto cells used to produce fibrosis, which can lead to cirrhosis, right? So stellate cells stimulate actually the fibroblast, and the fibroblasts lead to fibrosis, which can lead to cirrhosis. That was the function of TGF-beta secretion in the liver. So they increase the fibroblast activity, which lead to an obliteration of the bone marrow with fibrosis. You are going to hear about TGF-beta in the following disease. Pulmonary fibrosis has a lot of TGF-beta. Cirrhosis, a lot of TGF-beta. Myelofibrosis, a lot of TGF-beta. Repair of wound with a lot of scar tissue formation, a lot of TGF-beta. Basically, I want you, whenever you see TGF-beta, not TGF-alpha, to think, whenever you see a TGF-beta, about fibrosis. So the diseases again, pulmonary fibrosis, myelofibrosis, and cirrhosis. Okay? Pulmonary fibrosis, myelofibrosis, and cirrhosis, and scar formation. Okay, so let's see. It's associated with massive splenomegaly and the teardrop cells in the RBCs. What is a teardrop cells? So first of all, let's take a look at the bone marrow. You can see the fibrous tissue everywhere here. Basically, you cannot see anything. That's exactly what I mean. That's a lot of connective tissue. Yep, it's fibrosis. And this teardrop cells, why it occurs? Well, basically, let's imagine that this is the bone marrow. Okay, bone marrow is here. And we have a lot of megakaryocyte, a lot of fibrosis. Absolutely, it will be squeezed out, which lead to a teardrop cells, right? Yep. Okay, good. So the bone marrow cries because it's fibrosed and it's a dry tap. The other disease that I told you about that had a dry tap, which one was it? Hairy cell leukemia. Please do not confuse dry tap with biopsy. These are totally different. If you take a look at this, this is not coming from a tap. You know, a dry tap basically means nothing will come out. So what is the difference between a bone tap and a biopsy? A bone tab, you just insert a needle and you aspirate some of that fluid inside of the bone marrow. That's when you get the dry tab. But what about this picture? This is a bone marrow biopsy in which you put like a curved object that helps to take a piece of the bone marrow, okay? So Polycythemia Vera will have a lot of RBCs, a lot of white blood cells, and a lot of platelets. I see this all the time. People make mistake thinking that in Polycythemia Vera, it's only the RBCs. This is incorrect. All lineage are increased. Philadelphia chromosome, however, is absent. It's only present in the CML. The Jackiestad mutation is present. Essential thrombocythemia, it's only the platelets. No Philadelphia, and sometimes the Jackiestad can be positive, but not always. Myelofibrosis, well, we have destruction of the bone marrow, so the RBCs will be down. White blood cells and the platelets, it's highly variable because it depends how bad is the bone marrow is fibrosed. It's not associated with the Philadelphia chromosome, but it also has an association with the Jackiestad. CML has association with the Philadelphia chromosome, which was what? It was the translocation of the 922, the BCR-ABL, right? A tyrosine kinase inhibitor. A tyrosine kinase. And the RBCs will be down because they destroyed in the bone marrow, where the white blood cells and the platelets will be high. Okay, so it's associated with the Philadelphia chromosome, but not with the Jackiestad. Good. Does imetinib actually work, guys? There is a medication called imetinib, which is a tyrosine kinase inhibitor. Is it, I mean, CML is really horrible disease. Is it improving the survival? I mean, is it good, or we just give it symptomatically for symptoms? Not really. It actually works. It works. And it works by decreasing the problem, but you need to use it chronically for all life. It's an amazing medication that made a big revolution in treatment in CML. I mean, there is 90+% chance of the patient having normal life. In general, with leukemias right now, as of 2022, there is 85% chance of survival. I'm not saying survival meaning like living forever happily ever after. You will have to go through many chemotherapies, which are not pleasant. But still, you have a manageable life that you can live long life with a minor requirement of hospitalization, which is what we need to have as doctors. The least amount of hospitalization and make the patient live the longer period of that life possible. So leukemoid reaction and CML. What is the difference between them? The leukemoid reaction, it's mainly because of some inflammatory condition, right guys? But the CML is an actual cancer. Do you remember what was the thing that I told you we need to check to differentiate if it was an inflammation or leukemia? I mean, yeah, the LAB. So when your white blood cells, like neutrophil, for example, are high, and you need to make sure, well, is that the inflammation, like a responsive inflammation, or is it an actual cancer? You check the LAB. The LAB should be increased if the white blood cells were normal, such as in case of the inflammation, which is the leukemoid reaction. But in case of cancer, like CML, it will be decreased. So leukemoid reaction, it's a reactive in neutrophilia, more than 50,000. There might be toxic granulation, something called the Dolly body, I will show it to you, and cytoplasmic vacuolation. The lab score is going to be high, but there will be absence of the basophils and the eosinophils. The Dolly body, just a momento. It's just an abnormal type of RBCs. Okay, nice. So as you can see here, it's a continuous type of neutrophil, okay? That is basically looking weird. It's like, you know, neutrophil must have 3 separated lobes, but these lobes are not separating, right? The same with the toxic granulation, there is no separation. And the toxic vacuolation, you can see the vacuoles inside of the nucleus. So keep in mind that the lobes, yep, should be different. Okay, so CML, Proliferative Neoplasm, which is positive for the BCR-ABL, which is a translocation of 922 chromosome, and it encodes for tyrosine kinase, and it can be inhibited with amitinib. So the neutrophil morphology, we have the pseudobiglar-Haut anomalies, which I'm going to show it to you. Anyhow, we have a lab score will be much lower. Why? Because it's lower in malignant neutrophils. The eosinophils and the basophils, however, are going to be high, and they are only high in this disease. So let's take a look at this. Just a momento. I hate this cell. Should be bilobe, just a momento. If you remember the myelodysplastic that converts to CML, we spoke about it before. In that one, I showed you, oh, okay, good enough. Okay, that's good. In the myelodysplastic syndrome, I showed you a type of neutrophil that was bilobed, right? Then we spoke about this guy. It's exactly the same. Remember in myelodysplastic syndrome, which is this one, we also have the pseudobiglar-Haut anomalies, which we had the bilobe type of a neutrophil, and I told you this patient have high risk of converting into AML or CML. Okay, so the next thing we are going to speak about now is polycythemia. We have relative, an appropriate absolute, inappropriate absolute, and polycythemia vera. Let's say somebody is dehydrated, and basically this is his blood test. Normally our blood test should have RBCs, which goes downward, and we have like 1% of platelet/white blood cells, right? And the rest is plasma, right? So if somebody is dehydrated, which of the three is going to decrease? Is it the white blood cells? Is it the plasma? Or is it the RBCs? What do you think? In case of dehydration and burn, absolutely, it will be the plasma decreased. So relatively, the RBCs are going to increase, but this is not true. If you check the hematocrit in a dehydrated patient, it's always high. This is a common tricky question, of course, not in the USMLE, but on other state examination. They can ask you, for example, this patient who is dehydrated, why? Which test can you check for dehydration? The answer is hematocrit. Hematocrit will be high because of relative polycythemia. So it's because the plasma level is down. Actually, the other stuff are going to be absolutely normal. Appropriate absolute, and we have inappropriate absolute. So the appropriate absolute is because we have an actual increase of EPO, which is erythropoietin, right? So it's inappropriate that we will have polycythemia. So let's see what happens. During lung disease, we have hypoxia. Congenital heart disease can lead to hypoxia. High altitude can lead to hypoxia. Hypoxia is going to make the kidney suffer, which increases the EPO. And when the EPO is high, well, wait a second. All of these disease, first of all, I told you they lead to hypoxia. So the O2 sat is going down. So the EPO from the kidney is going to increase, so the RBC mass is going to go up. Inappropriate absolute. So it's somebody getting an increased EPO when he should not have increased EPO. Normally, EPO only increases in case of reduction of the O2 sat. But in this case, they are not. There is something off. What is it? It can be one of two conditions. The first one, exogenous EPO, which is doping, right? Like athlete abuse, we spoke about it. Like cyclist, for example, who want to keep cycling without getting tired. So yeah, that will increase the EPO, increase the RBC mass, but the O2 sat is actually normal. And also inappropriate EPO secretion, especially in somebody with malignancy, like renal cell carcinoma or hepatocellular carcinoma or hemiangioblastoma. Hemiangioblastoma. Again, hemiangioblastoma, which is a part of the HARP mnemonic, right? In which like we had patient like having hemiangioblastoma, angioma, renal cell carcinoma, and pheochromocytoma. So polycythemia vera, in polycythemia vera, the situation is like this. The problem is in the Jackiestad. The Jackiestad is not even related to the EPO. It happens after the receptor of the EPO. So the Jackiestad mutation, it's a downstream regulation of the EPO. So in that disease, the EPO will be actually down, but the RBC mass is going to be up. And as a compensation, the plasma is going to be up, but not as much as the RBC. So EPO decrease in Polycythemia Vera due to a negative feedback suppressing the renal production of EPO. So we have a chromosomal translocation. It's this table. We saw it before, but separately. Now we see it all in the one page. So it goes something like this. The translocation BERK 814. So BERK 814, it was lymphoma, the c-Myc activation. Remember, a c-Myc is a transcription factor, and it's a gain of function and mutation of this oncogene. Remember, please, that patients with Burkitt lymphoma mostly have the jaw lesion or the abdominal lesion. The next disease is the translocation. As you can see, we have 4 men. Remember the 4 men with the coffin? The African guys? Absolutely. So it's 4 men with the coffin, mantle cell lymphoma. They have a cyclin D activation and mutation, which leads to hyperproliferation. Keep in mind that a mantle cell lymphoma is highly fatal. Marginal zone lymphoma, it's 11-18. So it's, the margin of becoming an adult, it's during your teenage years, which is between 11 years old and 18 years old. You are at the margin. If you go over that, you are not at the margin anymore, okay? So, and if you remember, when you was between 14 and 18, you was such a fool. I personally was such a fool during this age. So that was follicular lymphoma, okay? The BCL2 activation, which can lead to, guys, when we activate the BCL2, will we have apoptosis or we will not have apoptosis? We will not have apoptosis because the BCL2 is a protector of the mitochondria, which presents the release of the cytochrome C, which normally activate the caspases. Then that used to lead basically to apoptosis. Okay, the translocation 1517, this one is highly atypical. What do I mean by atypical? Notice all of the ones we mentioned so far, it was like either 2 even numbers or 1 odd number and 1 even number. The only case in which we have 2 odd numbers was the translocation 1517, in which we have this acute bromialocytic leukemia. It's an atypical type of leukemia, and that's formally known as the M3 type of AML. Please make a note that this one is treated by retinoic acid. This one is treated by retinoic acid. Translocation 922, Philadelphia chromosome. So we have a CML BCR ABL hybrid. It's a tyrosine kinase mutation in which we will have a humongous amount of proliferation of the cell. The immunoglobulin heavy chain on the chromosome 14 are constantly expressed when other genes are translocated next to the heavy chain gene region. So if you have a translocation to the chromosome 14, such as like the c-Myc or even like the BCL, and that is going to lead basically to constant activation of the immunoglobulin heavy chain, which will lead them to be overexpressed, which basically means the cancer will occur, right? And next disease we are going to speak about is something known, actually this for one moment I want to repeat here. So let's say that we have a chromosome 14 here, okay? At this region we have the immunoglobulins, and the translocation is going to come, I don't know, chromosome 8, chromosome 18, 11, it doesn't matter. So that gene is going to come here, right? If it was an oncogene, it's going to stimulate the immunoglobulins to be hypersecreted, overexpressed. And that overexpression is going to increase humongously the amount of B cells, which promote the creation of the lymphomas, right? So Langerhans cell histiocytosis. This disease, they used to tell me it's not high yield, it's not high yield, it's not high yield. I got 3 questions from it on my exam because it's not that high yield. It's super high yield, guys. Don't listen to them. So Langerhans cells histiocytosis, but actually you need to know what is high yield in it. A collective group of a proliferative disorder of Langerhans cells. Wait a second, what is Langerhans cells? Langerhans cells is a type of dendritic cells slash macrophage. So, but a macrophage of what? Each organ had his own macrophage. I mean, in the liver we had the Kupffer cells. In the lung we had the dust cells. Excellent, somebody said skin. And he's right, the Langerhans cells are the macrophage of the skin. Okay, so it presents in a child as lytic lesion. Oh, if you can see here, you can see the lytic lesion. What was the other disease that had a lytic lesion like this? Multiple myeloma, absolutely. And they also have the skin rash because, after all, don't forget, Langerhans cells are a macrophage of the skin. Or as a recurrent otitis media with a mass involving the mastoid bone. So the mastoid bone can have an actual tumor, and that tumor, when it's big, it's going to lead to compression of the middle ear, and that is going to lead to recurrent otitis media. Cells are functionally immature and are not effective to stimulate the primary T cells via the antigen presentation. They are saying in a respectful way, and the patient has an immunosuppressed state. Okay? All of what I said is totally not relevant, not important. Maybe the lytic bone lesion is important. Other how, it's not really important, the other things. What is super high yield is the following. These cells, the Langerhans cells, I mean, they express S100 positive, okay? Which means they are from mesodermal origin, and they also express the CD1A. They love to ask about this. CD1A was a question, S100 was a question, and they show you this picture, okay? So what is this picture? If I took a biopsy of this lytic lesion and I put it under electron microscopy, I'm going to see this tennis racket. See, this is a tennis racket. So what they say, a bare Bicky granules, a tennis racket, or rod shape on electron microscopy are characteristic. So let's take a look at this bare Bicky granules. Oh yeah, so you can see how they look like tennis rackets. They are, where did they get them from? They got them from the lesion, and that was the lytic lesion. Remember, please, in the Langerhans cells, they do have a rash and they do have a lytic lesion. It is S100 positive. Okay, the next disease is tumor lysis syndrome. I'm just going to finish until here and then we'll have a break. So tumor lysis syndrome, when the tumor cells, you do chemotherapy on them and you try to treat the patient, right? You can have a massive destruction of the tumor cells. Well, that's amazing. Not really. Look, if you treat the cancer super quick and the cancer cells all destroy spontaneously at the same time, that means that basically you are going to have a plenty of stuff secreted into your circulation. What is the main electrolyte inside of the cell? Potassium, guys, potassium. Remember when I told you potassium is mainly inside of the cells and sodium is mainly outside of the cells? Yeah, so potassium is going to go now to the outside because the cell has ruptured, which can lead to muscle weakness because it was responsible in the repolarization process, not the depolarization that was sodium. So it can lead to constant repolarization, which lead to muscle weakness. Also, don't forget that it also contributed to the typical cardiomyocyte action potential. If you remember, this phase and this phase and this phase, this phase and this phase, both of them had a relationship to the potassium channels. Also, what happens that somebody said phosphate, you are right, so the phosphate is going to increase. And remember, phosphate can chelate. Chelate means bind to and destroy. So phosphorus can bind to and destroy the calcium. That can lead also to an ECG problem and also can lead to seizure and tetany. Don't forget about something called Ashvostic sign, which is tapping on the facial nerve, lead to grimacing on the face, and also the Trousseau sign, in which inflating the blood pressure cuff is going to lead to basically the obstetrician hand and tetany. Okay, so increase in the phosphorus will lead to calcium phosphate crystals, which is going to lead to acute kidney injury. High uric acid will lead to uric acid crystals, which is going also to lead to kidney stones. This is no fun, guys. We need to prevent the kidney stones. If you don't, the patient can have hydronephrosis, and that can lead to destruction of his kidneys. Okay, what should we do? What should we do? Well, when you start an invasive chemotherapy like this, make sure you give medication such as allopurinol and rosuburicase to prevent the hyperuricemia, but that's not enough. You need to do an aggressive hydration, and this is always the correct answer on the exam. Nice. Okay, good answer, hydration. So aggressive hydration basically dilute the other ones which prevent the death. So it's an oncological emergency, and this is the only emergency that an oncologist will say. Everything happening really slow. Even cancers, like you think that they are rapidly dividing and they can kill the patient right away. No, cancer is slow in killing the patient. It's not cardiac arrest right away. It takes time. So oncological emergency triggered by a massive tumor lysis and seen often with lymphomas and leukemia, usually caused by the treatment initiation. So when you start the treatment, but can occur spontaneously with a fast-growing cancers. I just want you to have an idea about how do we choose the chemotherapy for the patient. There is multiple ways of choosing the chemotherapy. For example, we do know the like the tumor type, and we know exactly which chemotherapy works at. But let's say that we have no idea. What can we do? Remember the microbiology culture we spoke about? We make a media, and in this media, we inoculate the cancer cells, and they are going to fill the whole media, right? And we make little dots on it. So for example, let me actually make this here, just a second. So let's say that this is our media, right? And this is the black stuff is all cancer. I just put cancer cells and made them proliferate all over the place. Next, I put one type of chemotherapy here, and one type, and one type of chemotherapy here, and one type of chemotherapy here, and one type of chemotherapy here. Okay, so let's make this. And after I put this chemotherapy, I see that the white stuff, let me just put numbers 1, 2, 3, and 4. I see the following. Which one of these 4 do you think I should use on my patient as a chemotherapy? The answer is absolutely 4. It must be 4. Why? Because it's killing the tumor in the best way possible. It's leading to a huge destruction of the tumor. Does that mean that I just can inoculate the tumor in a media and know exactly which chemotherapy to use? Yes. This is not long have been used. I'm speaking about less than 10 years time. This is the method that is used right now. It's you hear about the word cutting edge medicine. This is the cutting edge medicine. This is how you determine which chemotherapy you need to use on your patient that will actually work. Back in the time, they had something called the shotgun method. What is a shotgun? It's basically a type of rifle that shoots so many bullets at the same time. So they used to give so many chemotherapy, basically screw up the patient, and the patient has really severe side effects, and most of the time not really treat the cancer because they used to use, for example, 1. But the cancer requires 4. Maybe for another cancer, 1 will be perfect, but for this cancer, we need 4, right? So this is how we decide which chemotherapy to get. Okay, anyway, so we have release of potassium can lead to hyperkalemia. Release of phosphorus will lead to hyperphosphatemia. Do not forget that phosphorus can chelate the calcium, which lead to hypocalcemia due to calcium sequestration by the phosphorus. And also will have more in nucleic acid. Why? Because remember the increase in nucleus to cytoplasmatic ratio. And back then, I told you this is caused by increased amount of DNA, which made out of a nucleic acid. So when the nucleic acid is destroyed, it is, of course, the nucleic acid has many stuff in it, including purines and pyrimidines. So the purines are going to make us uric acid, which lead to hyperuricemia, which is going to lead to acute kidney injury. So prevention and the treatment include aggressive hydration, allopurinol, and something called rosuburicase, which convert uric acid to something called allanitoin, which is going to go outside of the body. The last disease we are going to speak about is Hemophagocytic Lymphohistocytosis, Whenever I see this disease, I think about cannibalism. What the? Yeah, cannibalism. It's a systemic overactivation of macrophage and cytotoxic T cells. Basically, your immune system becomes crazy and he starts to eat your own cells. I mean, eat, literally. So, how do they represent it in the exam? They mention for you somebody with fever, all types of cells are down, and he has really big liver. However, the ferritin will be high, okay? You are like, okay, so what happens exactly? What is causing it? Well, the causative agent include malignancy and EBV, but this is not the problem. The main problem that the macrophages are actually eating our neutrophil, RBCs, and other lymphocytes. So the macrophages are eating everything else. So that is Hemophagocytic Lymphohistocytosis. They love to show you a picture of it. Hemophagocytic Lymphohistocytosis. They love to show you a picture of it. It's not that difficult to see that this macrophage has a freaking it has neutrophils in it. This macrophage has lymphocyte in it. This yeah. So basically, the macrophage will have other types of cell inside of it, which should not be like this. You know, just yeah, unorthodox. So you can see how it has the neutrophil inside of it. So this is the hemophagocytic lymphohistiocytosis. Okay, so that's what they say. Bone marrow biopsy would show macrophage phagocytosing other bone marrow element. It's induced by EBV infection and malignancy. So now, after the break, we are going to speak about heparin, warfarin, and we'll keep going until today we finish this thing, hopefully. But I really hope, guys, that you utilize the days before to revise the chemotherapy stuff, because without that will be difficult for you guys. So see you guys in 10 minutes. Back. So let's take a look. So now we are going to speak about the medication. If you understood the physiology and the pathology normally, the medication should not be an issue. Let's start with heparin. They say keep the baby happy with heparin. What does that mean? So during the pregnancy, we are allowed to use heparin as an anticoagulant, but we are not allowed to use warfarin during pregnancy. Why? Heparin is a large molecule. It's super big molecule. And that is why it cannot cross the placenta. If it cannot cross the placenta, that means that the patient will not have what? He will not have like bleeding in the baby. Okay, heparin, the mechanism, it activates the antithrombin 3. And can you tell me any disease in which the antithrombin 3 is decreased? Absolutely correct. You are correct. It was the Nephrotic Syndrome. The Nephrotic Syndrome. Okay. So let me just take a look here. 3, 4, 5, 6, 7, 8, 9. Okay. So the first of all, we have it activates antithrombin, which decreases action primarily of factor 2 and factor 10. Remember, please, both factor 2 and factor 10 are in the common pathway. They are not in the intrinsic pathway. They are not in the extrinsic pathway. So now I have a question for you. Do you think the BT or the BTT will be increased? Excellent answer. It's both of them. So BTT mainly, that's true, that's what we monitor, but actually both of them will be increased. So clinical symptoms, immediate anticoagulation of the pulmonary embolism. So we can use it for a BE, pulmonary embolism. And where does the pulmonary embolism come from? The answer is deep venous thrombosis, which are in the leg. And acute coronary syndrome, we can use it for that. Remember, please, in acute coronary syndrome, we spoke about something called the monabash. In which we had like morphine, oxygen, nitric oxide, aspirin, beta blocker, and the other A was for ACE inhibitor, and the statin, and finally heparin, right? Monabash. So monabash is what do we use for acute coronary syndrome? Monabash. If you did not have the time to write all of that, just Google Monabash acute coronary syndrome and you will see it. Okay, so they write, used it during pregnancy because it does not cross the placenta and we need to monitor the BTT. The adverse effects include obviously bleeding, and it's reversible with giving a drug called the protamine sulfate. Please memorize this factoid because they do ask about it. And it can lead to something known as HIT, or heparin-induced thrombocytopenia, also osteoporosis for the long-term use, and the drug-drug interaction. Let's start with HIT. HIT has two types, HIT 1 and HIT 2. HIT 1 is mild, HIT 2 is horrible. So in HIT 1, the platelet count decreases, but it stays more than 100,000. Please keep in mind that if it is more than 100,000, it's highly unlikely to lead to any symptoms. Why? Because I told you that the bleeding starts when the platelet count go under 30,000. Absolutely. So in case of HIT 1, you will just see it on the labs. You will not see a patient complaining from it. So it's a transient non-immunological drop in the platelets, so there is nothing involved in the immune system and it will go away. It's a transient. It typically occurs within the first 2 days of heparin administration. It is not clinically significant. This is important. It has zero clinical significance. HIT 2, however, is the USMLE favorite. It development of an IgG antibody against a heparin-bound platelet factor 4. Anybody remember where does the platelet factor 4 come from? Platelet factor 4. Where does it come from? I will give you a hint. It's somewhere from the platelet. We had something known as the dense granules, and we had something known as the and the alpha granules. So look, anything that has F in it, it is going to be the alpha granules. No, anything that has F in it, it's going to be basically an alpha granules. Okay, alpha has a Fa in the name, right? Alpha. So that is going to have platelet factor 4. So platelet factor 4 is going to be in it. Okay, so that basically typically occurs 5 to 10 days after heparin administration. In the dense granules, we had like the ADP, we had the calcium, while in the alpha granules, we had all of the Fs1, like fibrinogen and the platelet factor 4. Antibody heparin platelet factor 4 complex, so it's 3 molecules together. An antibody, a heparin, and the platelet factor 4 will go together and they will bind and activate the platelet. And when they activate the platelets are going to clump into each other. You are like, okay, that sounds like thrombosis, not thrombocytopenia. Yes, because of formation of that thrombus, it's going to be tried to be removed by the spleen, of course, and also it can lead to thrombosis, which basically lead to a huge consumption of the platelet. When you consume the platelets like this, the platelet count is going down. So it is having highest risk with unfractionated heparin. Wait, what? Unfractionated heparin. Why? Is there a different type of heparin? Yes. Remember, I told you the heparin has a huge size, right? That's why we use it in case of a pregnancy, because it does not go to placenta. And this is actually, guys, since it has a huge size, can it be absorbed from the intestine, or should I give it like with an injection? What do you think? Absolutely, it must be with an injection, either intramuscular or IV. It cannot be in an oral form. Basically, it's too big to be absorbed by the intestine. However, we have made another type of it, is known as low molecular weight heparin. It has much smaller size, such as enoxaparin and dalteparin, and they act only at the factor 10. They do not act at the factor 2. Fondaparinux acts only at the factor 10. I have a question for you. Would you like to use this medication, and can you use this medication in a pregnant lady? What do you think? You should not. Why you should not? They have much more lower molecular weight. So there is a possibility for them to go through the what? The placenta, right? The placenta is like a filter, guys. So if it was normal heparin, he's big. He cannot go through. But a low molecular weight heparin might go through, right? Thus, you should not give it in a pregnant lady. At least for now, as of what I have read, they write it's unknown that if it is fine to use it in a pregnant lady still or not. So we highly don't know. It's highly likely that we cannot, but still, there is no final study. In Sketchy, they mentioned that it's safe. Nice. Okay, let me do this. So molecular weight heparin. Safety. Going to check which category it is because this sounds a little bit fishy. I will send you after the class. So have a better bioavailability and 2 to 4 longer half-life than unfractionated heparin, which is amazing. So keep in mind that unfractionated heparin is mainly used for a pregnant lady. The lower molecular weight are becoming more predominant in the market right now because they tend to have like difference in the the checking of the BTT stuff. I mean, if you take normal heparin, you need to keep checking the BTT of the patient. But if you take the low molecular weight heparin, they do have a little bit wider therapeutic dose, which allows you to manipulate the dosages a little bit in a better way. So I hope you remember what is therapeutic dose, which is the difference between the toxic dose and the effective dose. They write, low molecular weight heparin undergo renal clearance versus hepatic clearance in the unfractionated one, and may be used with caution in patients with renal insufficiency. So if they give you somebody with high creatinine, be like, okay, maybe I want to use the one that has hepatic clearance, which is like normal heparin. But if they give you a question about unfractionated one, if they tell you about somebody with alcoholic cirrhosis, for example, you're like, okay, maybe I would like to use the one that is cleared renally, which is the low molecular weight heparin. So let's see the other one. So next one is warfarin. Never do use this one, which is the warfarin in case of a pregnancy. Why? One, they can pass through the placenta, which is going to lead to pathology in the patient. Okay? So, okay, so apparently you guys are right. I just checked. They write low molecular weight heparin is considered as category B, and thus it have shown to be safe during for the fetus. It's safe for the fetus. Okay, I really did not know that. That's nice. Oh, okay. So be careful, however, that it can be only administered after 28 weeks of gestation, not before 28 weeks of gestation. Okay, nice. So they write here the Warfarin mechanism. It inhibits vitamin K epoxide reductase by competing with the vitamin K, which inhibit the vitamin K dependent carboxylation. They love to ask which of the following reaction is most likely the way that warfarin works. Is it by directly inhibiting the carboxylation of the clotting factor, which is wrong, or is it by binding to the epoxide reductase? The answer is the epoxide reductase. If they ask you overall what is going to happen, we will have less carboxylation of the clotting factor. Which clotting factor? 1972, which is a clotting factor 10, 9, 7, and 2. 10, 9, 7, and 2. Right. And also protein CNS. Metabolism affected by polymorphism in the gene for vitamin K epoxide reductase complex, which means basically that different people have different form of metabolism for the vitamin K. This can be a little bit problematic. Why? Because that means I need a different dose than you. You need a different dose than your friend, you know? So each person require a different dose from each other. So how can I deal with that? I will tell you. So in the laboratory assay, it has an effect on the extrinsic pathway and increases the BTT. So you need to check the BT, which is not BTT, sorry, the BT, prothrombin time. And it has a long half-life, which can promote to toxicities. Guys, just take a look at this. Clinical use is this much. Adverse effect is this much. This drug is serious. It has so many adverse effects, which means that you need to highly make sure that you are giving the correct dose. Okay? I will tell you how. Look, the thing about heparin, it's giving IV. So IV or IM. So do you think it's convenient for the patient to give him an IM or IV drug all the time? It's not really convenient. So what we do actually, during the period of time in which the patient is in the hospital, we give him heparin. But if he's going back home, we would like to switch him from heparin to warfarin. Why? Because warfarin is taken up orally. Okay? So if that is the case, you are like, wait a second, but warfarin causes a transient hypercoagulable state and then lead to the hypocoagulable state. I agree. So during this phase, in which warfarin causes to the hypercoagulable state, we give heparin. Until the patient passes this phase, you start giving only warfarin, which lead to hypocoagulable state. So they write here that and actually heparin is still a little bit more safe, much more safer than, for example, warfarin. Warfarin is much more dangerous. So what they write here: chronic anticoagulation for venous thromboembolism prophylaxis and the prevention of stroke in case of atrial fibrillation. In the USMLE Step 2 exam, you will learn the actual criteria that you need to hold in your hand and be like, okay, the patient is a smoker plus, the patient is more than 70 plus, to allow you to know which type of anticoagulant you should utilize. For the USMLE Step 1, you don't really need to know that. So people with atrial fibrillation have stasis, which increase the risk of formation of thromboembolism, which can lead to stroke. So for that case, we do give warfarin to prevent them from getting the thromboembolism. Or, even better, just to treat the atrial fibrillation, but do not treat it before making sure that the patient does not have a thrombus. And what do you think? What will be much more sensitive? Is it a transesophageal echocardiography or a transthoracic one for checking for basically a thrombus inside of the left atrium? You are absolutely correct. It's a transesophageal one. Why? Because the left atrium is the posteriormost chamber of the heart. Yep. Good. So we do not use warfarin in a pregnant lady because warfarin, unlike heparin, it crosses the placenta. So you would not like a baby to have warfarin. Don't do war on warfarin, on baby. Keep the baby happy with heparin, right? So you monitor the BT and the INR. You are like, the BT, I got it, no problemo. I understood that I check the BT because the patient is mainly having pathology on the extrinsic pathway, not the intrinsic pathway. And the proof of that was that he has involvement of factor 7. And factor 7 involves the extrinsic pathway. So that's why I decided to choose the extrinsic pathway monitoring. But what is this INR? Well, the definition of INR, yes, we also have the common ones, and like 2 and 10. We have also ones that come from the intrinsic pathway. So why are you telling me we only get the BT and not the BTT? Because it's highly specific for warfarin. While if we speak about heparin, heparin does not have any factor from its factor related to the intrinsic pathway, right? To the extrinsic pathway. And thus we prefer to use BT for the extrinsic pathway. Remember, blatant is outside. So because of the factor 7, we do that. Okay, so there is a few notes here. The INR, the international normalized ratio, yes. What is it? It's the BT in our patient compared to the BT of the whole population. Okay? So this is the BT of our patient, and this is for the whole population. So the difference, the ratio between these two, this is the INR. So we need to check the INR, and we need to make sure that it stays between 2 and 3. If it becomes more than 3, reduce the dose. If it becomes less than 2, increase the dose. And that's how you deal with warfarin. You are like, wait a second, but this requires a frequent checking. Absolutely. Every other day, like some doctors prefer to do it every 4 days. Some doctors say every week. You need to do the blood test to check for the INR. The adverse effect of warfarin, however, is bleeding, obviously, teratogenic effect, that's why we don't give it in a pregnancy, and the skin and tissue necrosis, as you can see here. Look how messed up this is leading to the patient hand here. Okay, so, and the drug-drug interaction, and it can be metabolized by something known as the cytochrome B450. So if I use an inhibitor of the cytochrome B450, what is going to happen to the dose of warfarin? I mean, the plasma concentration of warfarin. Increased, absolutely, it's going to be increased. So if I use rifampin, which is a stimulator of the cytochrome B450, what is going to happen to the level of warfarin? Decreased, absolutely, it's going to be metabolized much more correct, which is going to lead him to be decreased. Okay, nice. I like when finally like, you know, when you start to get the material, like you can just speak freely and you are just getting 1 or 2 new concepts from each statement. This is good. That means that you are almost there. We are actually, guys, 60% done with the material. Initial risk of hypercoagulation. Protein C have a shorter half-life than factor 2 and factor 10. That means your protein C, what was the protein C? Was it a procoagulant or an anticoagulant? An anticoagulant. They say they have a much shorter half-life. And warfarin inhibits it, so it's going to disappear much before the factor 2 and factor 7. So that means for sometimes your factor 2 and factor 10 are going to be much more increased. If that is true, the patient is going to have a transient and initial hypercoagulable state. But after some time, also the factor 2 and the factor 10 will also decrease. And that will lead to a hypocoagulable state. So as you can see, if I'm going to speak about the coagulability in this thing, if they are going to draw a graph for you, it must be something like this. So let's see. Initially, you give the warfarin, so it must be something like boom. This is hypercoagulable state, and then hypocoagulable state. So if they ask you, oh, the hypercoagulable state, was it due to a deficiency of what? What was decreased? Why the patient initially had a hypercoagulable state? What was decreased? The answer is protein C. Protein C, the anticoagulant. Because he was decreased, we had a hypercoagulable state. Okay, so what about the hypocoagulable state? What decreased and that led to a hypocoagulable state? The answer is basically the other factors, which are factor 2 and factor 10. Existing protein C depletes before existing factor 2 and factor 10, and before warfarin can reduce the other factors, which are factor 2 and factor 10 production, which lead to hypercoagulation transitionally. So they mention now this thing. The skin necrosis within the first few days of large doses, it's believed to be due to a small vessel microthrombosis. And why this happens? Because of a deficiency of the protein C. Okay, guys, back in the time, like a couple of classes ago, I told you about one pathology. We spoke about it really quick, but I told you I will come back to it. So now is the time. Just need to find it. 1 second, guys. Oh yeah, a protein C or S deficiency. I told you in this patient, they have more risk of warfarin-induced skin necrosis. So because protein C is an anticoagulant and warfarin also inhibit this protein C, That is going to exacerbate the warfarin induced microthrombosis of the small vessel, which lead to skin necrosis. This is skin tissue necrosis of warfarin is no fun, guys. So even if you take a look at it, it looks something like this. So this is no fun. This is super serious condition that it can be fatal sometimes. So you need to be really careful with it. Okay, so the next thing, they write heparin bridging. So again, so this was the hypercoagulable state, hypocoagulable state. So during this period, keep in mind that you can give what? Heparin, just transitionally. So heparin bridging, heparin frequently used when starting warfarin. Heparin activation of antithrombin enables anticoagulation during the initial and the transient hypercoagulable state caused by warfarin. Okay, so initially we can give concomitantly the two medication, warfarin and heparin, I mean. Until the hypercoagulable state ends, we can give the other one. Initial heparin therapy reduces risk of recurrent venous thromboembolism and skin tissue necrosis. For reversal of warfarin, give vitamin K, but this will take time to work, right? Because to basically give the clotting factor to work again and to do that whole process, you take 2 days. That's a lot of time. If you need it acutely, like after a toxicity, you need a fresh frozen plasma and also BCC. There was one thing that I want you to know. Guys, do you know what is, yeah, just I will show you. Rat poison. So rat poison, you know, like for rats, there is 2 types of it, okay? One of them works on the TCA cycle and the electron transport chain, but the other one, which is the more important one for me here, it's actually, guys, warfarin. We feed, yeah, see this comaran? That's basically warfarin, okay? So we give the patient, not the patient, the rat, see, first generation warfarin. We give the rat warfarin, and basically we cause the rat to have a hypocoagulable state, which is going to lead to him having intracranial bleeding and death. Of course, I'm a doctor, I don't care about the rat, but I'm teaching you this because some people who are suicidal can consume a lot of, you know, like rat poison to kill themselves, which means that you need to treat it like you treat what? A warfarin toxicity. So heparin versus warfarin. Heparin is parenteral, warfarin is oral. The heparin acts on the blood, while the warfarin inhibits the epoxide reductase in the liver. The onset of action, heparin acts super quick. The warfarin had the transitional hypercoagulable state, which is limited by the half-life of normal clotting factors. The heparin duration of action is hours, while warfarin is for the long-term type of thing. So for monitoring, we check the BTT for heparin and the BT and the INR for warfarin. Keep the baby happy with heparin, that means it does not cross the placenta, while warfarin does cross the placenta. So direct coagulation factor inhibitors. Let's take a look at this, guys. So they write, we have the bad ones. So if somebody has HIT, which is heparin-induced thrombocytopenia, what should I do? Well, you need to reverse the treatment. You cannot keep him in heparin, basically, because it's leading to heparin-induced thrombocytopenia. So that's bad. Because of that is bad, you give the bad ones. So biliverdin, ergotroban, and dabigatran. All of them are like the bad, BAD. So they are a direct inhibitor of the thrombin, which is a factor 2A. So they can be used for the exact same thing as heparin, which is venous thromboembolism and atrial fibrillation, but we only use it in case when the patient has HIT and you need something else. Let's say that, okay, I gave the dabigatran, and still, after that, I have like bleeding. What should I do? So dabigatran, right? So the bigatrane. So basically the bigatrane. When the bigatrane comes, I will tell him that I adore Susie. I adore Suzumab. I adore Suzumab. I adore Suzumab for the bigatrane. Okay? Adorisuzumab for the bigatran. The bigatran is the only oral agent in the class. So do not require lab monitoring, which is actually a big plus, but the bigger plus, it's its price. It's expensive. It's not that plus. Okay, I hope you watch Harry Potter. Epixaban, edoxaban, and rivaroxaban. Prisoner of Ixaban. So that works at the factor 10, obviously, because it has factor 10 in the name. So it's for treatment and prophylaxis for the DVTs and the BEs. Stroke prophylaxis in patient with atrial fibrillation again. So bleeding can occur as a side effect, obviously, and to prevent that, I mean to inhibit the bleeding, you can reverse the medication by giving an antidote known as andexanate alpha. So oral agent that do not usually require lab monitoring. We really like drugs that do not require lab monitoring because that means less clinic exposure, which is better for the doctor and for the patient. Anticoagulant reversal, heparin, we can use a protamine sulfate, which is a positively charged molecule that binds the negatively charged heparin, and that can lead to excretion of the heparin using the liver. Warfarin is a vitamin K. We can use vitamin K, but it acts slowly, so we need to use fresh frozen plasma and the BCC for quick reversible. The bigatran, you need to tell him that you adore Susie. So I adore Suzumab for the bigatran, which is a monoclonal antibodies Fab fragments. And the last one, we have a direct factor 10 inhibitors, such as the Ixabans, and for that, you need to use andexanate alpha, a recombinant modified factor 10, which is inactive. Okay, anti-platelet medication all works by decreasing platelet aggregation. So we have the following ones. Let's take a look. Just a momento. Yes. So the first one is aspirin, really commonly used. So it's an irreversibly blocks the cyclooxygenase, and that decreases the thromboxane A2, which take a role in the process of aggregation, not adhesion, aggregation, guys. So acute coronary syndrome and coronary stenting, and decreases the incidence of recurrence of thrombotic stroke. Okay, be careful, however, it can decrease the prostaglandins, which can promote the gastric ulcer. An overdose of aspirin can lead to tinnitus, and allergic reaction can occur sometimes, and also renal injury, especially interstitial nephritis. And, oh, sorry, not interstitial nephritis, my mistake. Remember, guys, aspirin reduces the prostaglandins. Prostaglandins normally vasodilate which arteriole of the kidney? Which arteriole of the kidney is normally vasodilated by prostaglandins? The efferent arteriole, no, it was the afferent. Efferent arteriole is vasoconstricted by angiotensin II. So it will be vasodilated by ACE inhibitors. But the afferent arteriole is vasodilated by prostaglandins. It will be vasoconstricted by aspirin. Okay. So clopidogrel, prasugrel, ticagrelor, and ticlodipine, all of these has a grel, except ticlodipine, he's weird. So anyway, you will see how weird it is. It even leads like a weird side effects. They block the ADP receptor. Remember this guy? The guy who led to the expression of the GB2B3A, which was responsible of aggregating two platelets together, right? So that will decrease the ADP-induced expression of the GB2B3A. The clinical use is the exact same as aspirin. And we can use it in a dual antiplatelet therapy in which you require two medications. So you can use aspirin and clopidogrel together. Or for example, in somebody with gastric ulcer, you would not like to use aspirin, so you use clopidogrel instead. Keep in mind that the patient can have neutropenia, which have, in case of ticlopidine, and TTP might be seen. Keep in mind, TTP is thrombotic thrombocytopenic purpura, in which the patient have hemolysis, thrombocytopenia, and also the neuropathy, which is highly characteristic of it. Epixaban, it works on the Fabians, the frogs, right? So ebetifetide and tirofiban, both of these block directly the GB2B3A, which are also responsible for the aggregation on the activated platelet. So they are the Ibiximab is actually a monoclonal antibodies with the Fab fragments. So we can use it in an unstable angina and also in a percutaneous coronary intervention. So keep in mind that this medication can lead to bleeding and thrombocytopenia. The last two medications that work on the aggregation are cilostazol and dipyridamole. This is the second time we speak about them. They block the phosphodiesterase, which lead to decrease in cyclic AMP in the platelets, which prevent the aggregation. We can use it in case of people who have atherosclerotic disease of their femoral artery, leading to intermittent claudication, which is pain on walking. They also prevent the stroke, and it can be used in cardiac stress test because they lead to vasodilatation. When they lead to the vasodilatation, there will be shunting of the blood to the, if we say like we have like one blood vessel, coronary artery, and it's going to two vessels, right? And the atherosclerosis is here, right? When you do vasodilatation, the healthy vessel is going to be vasodilated, while the pathological vessels is already like 100% vasodilated, so it cannot vasodilate more. So a Steele syndrome will occur, and by the Steele syndrome, it can be used in cardiac stress testing to check if the patient actually has coronary artery disease by promoting a Steele syndrome. A prevention of coronary stent restenosis. After you plug in a stent, remember we have two types of cardiac stenting. Coronary artery stenting. This is usually step 2. You have this drug-eluting stent and the metal stent. The drug-eluting stent has less risk of restenosis, but you must do aggregation. You must give treatment, proper treatment for 1 year. The metal stenting have more risk of like restenosis, but it has less risk of restenosis in the first year, but after the first year you have so much restenosis. So these medications lead to vasodilatation, which can lead to nausea, headache, and facial flushing. Because of the vasodilatation, also the patient can have hypotension and abdominal pain. The next thing I'm going to speak about is the thrombolytics. So the thrombolytics are as follows: altibase, ritablase, streptokinase, and tenecteplase. All of these guys work at the fibrinolytic pathway, so directly or indirectly help in the conversion of a plasminogen to plasmin, which leaves the thrombin and fibrin clots. So they destroy the clots themselves. So they increase the BT and the BTT, but they don't touch the platelet, because they work on the secondary hemostasis, not at the primary hemostasis. So we can use it in an early MI if you do not have a cath lab. If you have a cath lab, do not use this. It's not worth it. A cath lab is much better. Early ischemic stroke, in the first, until 4 hours, you can give it. After 4 hours, it's useless. Direct thrombolysis of severe BE as well. But if the BE was too big, it's better to get it out with surgery, not with this. Before giving it in somebody with ischemic stroke, you must do a CT scan to make sure that the patient does not have a hemorrhagic stroke and not an ischemic stroke. So bleeding can be an adverse effect, contraindicated in patients who have active bleeding or history of intracranial bleeding, recent surgery, non-bleeding diathesis, which is these people who have diathesis for bleeding are people who are more likely to bleed, like people with hemophilia, people with factor V laden stuff, and also severe hypertension, or people with von Willebrand deficiency, also people with who takes already an anticoagulant, also people with diverticulosis, okay? So non-specific reversal of antifibrinolytics can be used, such as aminocobroic acid or tranexamic acid, which we also going to speak about in reproductive system. And this medication can also be used to stop the bleeding in case of obstetric emergencies. Platelet transfusion can be given as well, and factor correction like cryoprecipitate, FFP, and BCC. Okay, so the next thing we are going to speak about now is going to be the what? Is going to be the cancer therapy. So the cancer therapy, first of all, we have the cell cycle. The cell cycle goes something like this. We have the M phase, which include the mitosis and the cytokinesis. Remember, the cytokinesis was the process of separating two cells away from each other. And also we have here like the G1 phase, in which we have like duplication of the cellular content to make more cellular content to prepare it for the DNA synthesis in the S phase. And after that, the proof checking is done at the G2 phase. The G0 phase, however, is the resting phase, whereas the permanent cells are located at. Remember, which permanent cells did we have? Any idea, guys? Cardiac, neurons, and skeletal muscles. Absolutely. Good. So they write here so many medication on this graph. I will be going through all of them, but in general, just take a look here. And no, the microtubule inhibitor work at the M phase because for the sake of separating the cells away from each other, we require microtubules. So microtubules inhibitor will work here. The antimetabolite will work at the purine and the pyrimidine synthesis pathway. So these will be working at the S phase. The topoisomerase inhibitor are working on the basically, how do you call it? They are basically working at the supercoiling formation, which can occur during the DNA phase or during the repair phase. So yeah, the topoisomerase inhibitor work at both S1 and G2 phase. On the exam, they will give you an actual picture of this, and they will be like, bleomycin, at which phase of the cell cycle it's working? And the answer will be like G2, for example, you know? So you need to know exactly which drug work at which phase. If I was you, I will just print this thing and put it in front of me. Okay, cancer therapy. So we have a nucleotide synthesis, and they become DNA, RNA, protein, and eventually we have cellular division. In each state, we have a drug working. So for a nucleotide synthesis, we can use methotrexate or 5-fluorouracil, which are basically going to decrease the thymidine synthesis. It's something we spoke about at the third page of first aid. Less thymidine synthesis basically means less DNA production, which basically means less cellular division, less proliferation. Thiopurines also decrease the de novo synthesis, and hydroxyurea inhibit the ribonucleotide reductase, which also inhibit the pyrimidine synthesis pathway. The DNA inhibitors, we have an alkylating agent which cross-link the DNA. If we have two strands of, actually let me just show you a quick alkylating agent. They cross-link the DNA, which prevents normal division. So if you take a look here, don't like this one. Nice. No, not that good. Just a second. Yes. Okay, so you can see the cross-linking of the DNA like this, which basically prevent the DNA from dividing normally and working normally, right? So that's the cross-linking. Okay, so they write here, bleomycin, we have DNA strand breakage in this case, which is due to a free radical injury. We have also anthracycline and actinomycins, which lead to they are in DNA intercalators, basically mess up our DNA, and that is going to kill the cancer cells, hopefully. It's going to kill our cells as well. Also, they make free radicals. Atibocyte, tenibocyte, they have two sides. We all have two sides. So we have inhibitors of the topoisomerase 2, while irinotecan, both of the tecans, and topotecan, inhibitor of topoisomerase type 1. Finally, the vinca alkaloid and the taxanes, they inhibit the microtubules, but the vinca alkaloid inhibits the formation of them, and the taxes build communities. So they inhibit the microtubule disassembly. Okay, so each of these, don't worry if you don't get what I just said, because each of these literally will be speaking about really deeply. So let me just speak about the antibody drug conjugate, and then let me just take a look here. So we have 1, 2, 3, 4, and 5, and this is the 6th one. Okay, so let's try to do a little bit from here. After that, we'll have a break. So an antibody drug conjugate, let's see what we have. Okay, so they are speaking about some drug that, some antibodies that we can utilize against cancer. That sounds cool. Yep, exactly. So an antibody that will directly go and bind to the cancer cells we will load up on them a drug. So that drug is going to go exactly at the cancer cells, enter inside of it, and then destroy only the cancer cells. This is super cool. Why? Because if you use such medication, what do you think? You will have more side effect or less side effect? Much less side effect. The main problem about chemotherapy, guys, it's not about is it successful or not. A lot of chemotherapy are successful. The problem is that sometimes we kill the patient from the side effect, not from the, he does not die from the treatment. I mean, not from the cancer, but from the treatment. So it's formed by a linkage of monoclonal antibody with a cytotoxic chemotherapeutic drug. An antibody selectivity against a tumor antigen allows targeted drug delivery to the tumor cells while sparing the healthy one. So we find and check for an exact antibody that only exists at this cancer cell. And we send an antibody which is loaded with a lot of chemotherapy directly against it, which killed the cancer cells while sparing all of the healthy one. Increased efficacy with lower toxicity. So examples include the trastuzumab amitinase, which are for the HER2 breast cancer. So, I trust her because she has breast cancer. Okay, that's horrible. But yeah, I trust her, and her is, her is lady, so breast cancer. Okay, so we use like directed antibody-mediated therapy. This is the cutting edge medicine we keep speaking about. Okay, guys, so let's have a little break, a 10 minutes break. We'll come back. We'll speak about the anti-tumor antibiotics, the antimetabolite, alkylinating agent, platinum, microtubule inhibitors, and we'll see. Maybe we'll continue this today, the last 3 pages, maybe tomorrow. So see you guys in 10 minutes. So you guys voted for yes. So someone voted for no. So, okay, I will try not to make it so long. So let's take a look. Anti-tumor antibodies. Anti-tumor antibiotics. So all are cell cycle non-specific. This is important. So they cannot tell you, oh, which phase of the cell cycle does this, for example, the actinomycin work or anthracycline work. It cannot be like this because they are non-specific. The only specific one is bleomycin, which work at the G2 phase and the M phase. And you can see it in the picture how bleomycin work on both of them. However, both of these are free. The bleomycin is a free radical generation, and they love to ask you about this and the mechanism it leads to the pulmonary fibrosis. Also, it can lead to breakage in the DNA strands. So the destruction of the DNA strands can lead to the tumor cells like Hodgkin's lymphoma or testicular cancer. By the way, the exact tumor at which anti-tumor medication works at, you should not know this exactly. Why? There is a few that you have to know about, and I will tell you which one you must know about. But in general, you should not know about it. Why? Because you are not an oncologist, okay? You should know the side effects. You should know the mechanism, but you should not know the exact clinical use except for a few tumors. So that can lead to pulmonary fibrosis and also skin hyperpigmentation. You must know that the pulmonary fibrosis is because of a free radical injury that is followed by activation of the TNF-beta that is going to lead basically to fibrosis. The actinomycins or actinomycins D, they intercalate the DNA, which basically means connected. So actually, let me show you how intercalation means. So if this is a DNA, intercalation is like if you get an object and you put it between the two strands, okay? I'm intercalating them, which yields them inactive, right? So that's intercalation of the DNA. Okay, so they write here, intercalates into the DNA, preventing DNA synthesis. Wilms tumor and Ewing sarcoma and rhabdomyosarcoma. So it can lead to myelosuppression, this medication. Anthracycline, like doxorubicin or daunorubicin, can be utilized as well. These also a free radical generator. And by the way, guys, myelosuppression is not like, oh, look, this drug lead to myelosuppression. Of course they lead to. All of them lead to, because they are basically inhibiting the rapidly dividing cells. That's why chemotherapy, all of them lead to the following symptoms. Less hair, right? The hair is going to fall down. What else? They have, why? Because the follicles are going to get destroyed. They also get diarrhea. How come? Because the crypts, right? The crypts is going to be destroyed. The crypts contain the stem cells of the GI. No normal enterocyte, that means it's sloughing off of the enterocyte, which means poor absorption. Poor absorption lead to diarrhea. Okay. Generative free radicals, which breaks down the DNA and decrease the replication, and also can lead to inhibition of the topoisomerase 2, which means no removal of the supercoil, which means really bad DNA synthesis. Can be used in solid tumor, leukemias, and lymphoma. All of these indications are not important for this patient. The only thing that I would like to you must know. Bleomycin causing pulmonary fibrosis. This is high yield. Anthracyclines, especially with the names, I mean doxorubicin and daunorubicin, they do ask about this. They want you to know that they can have a dilated cardiomyopathy due to a free radical injury. It happens, and it's often reversible, but you can prevent it before it happens if you use this medication, dexrazoxane, which basically prevents the Fenton reaction from occurring inside of the heart, which prevents the free radical injury in case of doxorubicin. They also led to myelosuppression and alopecia. Okay, why alopecia? Because of the follicles, hair follicles destruction. Antimetabolite, all of them work at the S phase except cladribine, which is a cell cycle non-specific. Okay, so let's take a look. We have the thioburines like azathioprine and 6-mercaptopurine. Remember the third page first aid. That page is important. So it inhibits the purine. It's a purine analog which decreases the de novo purine synthesis, which was the thing on the right. And azathioprine is converted to 6-mercaptopurine, which is the active form of azathioprine. For the sake of its activation, it requires something called the HGBRT, which was existing. Does anybody remember which disease can be caused if this enzyme is defective? Which disease can occur in case of HGBRT deficiency? I will give you a hint. This patient have self-mutilation and they have hyperuricemia. Any idea? Come on. Hyperuricemia, self-mutilation, diaper with, yeah, they can have gout as well. They have diaper filled with brownish stuff. Okay, so it was Lesch-Nyhan syndrome, guys. Lesch-Nyhan syndrome. Okay, so Lesch-Nyhan syndrome, it is because of inhibition of the HGBRT. Remember that you can see here the 6-mercaptopurine and the azathioprine working here. Soon we'll speak about the 5-fluorouracil and the cabazitaline and methotrexate working at the pyrimidine synthesis pathway. Okay, so let me go back here and speak about the purine synthesis a little bit more. So it can be used for the rheumatoid arthritis, inflammatory bowel disease, lupus, and why? Because these will destroy the immune cells, which can help in case of autoimmune disease. Also, we use it in case of ALL, acute lymphocytic leukemia. And also it can be used in steroid refractory disease because it also leads to inhibition of the immune system. It prevents organ rejection, and we can use it to wean off steroids. Like somebody is on a steroid for a really long time, you want to stop the steroid, you cannot stop it right away. So you need to decrease it slowly and start other medications such as azathioprine. So they can lead to myelosuppression, GIT, and liver toxicity. 6-mercaptopurine is inactivated by xanthine oxidase, which is an enzyme inhibited by allopurinol, and febuxostat. A common USMLE question: which of the following medications should not be utilized with azathioprine? And the answer is, well, allopurinol and febuxostat, and the reason is because the 6-mercaptopurine is inhibited by xanthine oxidase. So if you are already inhibiting it, the 6-mercaptopurine cannot be inactivated, so you will have a humongously high amount of it, which lead to toxicity. Cladribine and pentostatin, if you remember, they work at the adenosine deaminase, which increase the adenosine, which basically led to destruction of the DNA because it's toxic for it, the adenosine. Purine analog, multiple mechanism, inhibition of the adenosine deaminase and also DNA breakage. It's used for hairy cell leukemia, can lead to myelosuppression. Cytarabine or arabine phorencial cysteine, it's a pyrimidine analog, the thing on the right side. A DNA chain termination and inhibit the DNA polymerase, which means no new strands going to be made. So we can use it in leukemias and lymphomas, and it can lead to myelosuppression. The next drug is 5-fluorouracil. I just showed it to you. It was on the left, the pyrimidine synthesis pathway. And it's a pyrimidine analog bioactivated to something known as 5-FDUMB, and that is going to inhibit the thiamidylate synthetase, which is going to decrease the thymidine, basically no thymine, no DNA synthesis, well, no proliferation of the cell. The cabecitabine is a prodrug, and he is going to be converted to 5-fluorouracil. So it can be in colon cancer, pancreatic cancer, actinic keratosis, which is a pathology I'm going to speak about in dermatology, in which it's a precancerous lesion. So it's before the actual squamous cell carcinoma happens. We have something called actinic keratosis occurring. So you can see how actinic keratosis looks something like this. It is mostly on a sun-exposed area, and after some time, it's going to become an actual cancer. Okay. So basal cell carcinoma, it can be used 5-fluorouracil in a topical form, like a cream. Effect enhanced with the addition of leucovorin. So that makes it much more active. Leucovorin is basically going to promote more activity of the 5-fluorouracil, and reduces the amount of the destruction of the normal lymphocyte. So it can lead to myelosuppression, also palmar-plantar erythrodysesthesia, which is known as the hand-foot syndrome. What is this hand-foot syndrome? So the hand-foot syndrome, both of them, the hand and the foot, will be red, but in the same time, they are going to have a disturbance in the feeling. This disturbance of the feeling is going to be a burning sensation in the hand and the foot, okay? And they are going to be swelling, have a swelling in them, and it's going to be really, really painful for the patient. Okay, yes, something like this. It's no fun. Okay, so the next thing is hydroxyurea. Hydroxyurea, it inhibits the ribonucleotide reductase and decreases the DNA. Also remember, we used to use it in sickle cell disease, but it was a different mechanism because it used to increase the fetal hemoglobin. So the hydroxyurea also work on the pyrimidine synthesis pathway. It can be used for myeloproliferative disorder, such as BML and polycythemia and sickle cell disease, as we said, because it increases the fetal hemoglobin. It can lead to myelosuppression and megaloblastic anemia. So methotrexate is a folic acid analog that competitively inhibits the hydrofolate reductase, less thiamine, less DNA. It can be used for cancer or non-cancer things, so cancer things, leukemia, lymphoma, choriocarcinoma, and sarcomas. Non-neoplastic, this is, if I was you, like I told you guys, some stuff are high yield and some stuff is just like, you really don't have to know it. Like, for example, as a azathioprine, you must know about the rheumatic fever stuff. For example, the sickle cell disease, you must know about the hydroxyurea and the fetal hemoglobin. The other stuff, you should not know it. The hairy cell leukemia, you actually have to know about the cladribine and the pentostatin. So non-neoplastic usage of methotrexate are high yield. For example, ectopic pregnancy, if it was really early, or medical abortion, we use it together with misoprostol to kill the baby basically, and then to help to deliver it with misoprostol. So rheumatic arthritis and psoriasis, IBD, and vasculitis, basically autoimmune disease. It can lead to myelosuppression, but you can prevent the myelosuppression if you use leucovorin, which is basically a vitamin B9, but in a different form. They also like to call it folinic acid, not folic acid, but folinic acid. So it's used as rescue. Hepatotoxicity and mucositis can occur, which is basically multiple ulcer in the mouth. Pulmonary fibrosis, the other medication that is chemotherapeutic agent that led to pulmonary fibrosis was what? What was the other medication that led to pulmonary fibrosis? And it was a chemotherapeutic agent. It was the first one we spoke about, the bleomycin, absolutely. Folate deficiency can occur as well, and we can rescue it by giving the leucovorin. Don't forget about methotrexate, that it is nephrotoxic. Okay, who hate the Nazis? Raise your hand, because we are going to speak about the Nazis now. Nazis, chemotherapy, yep. They used to use chemotherapy, but in a bad way. Anybody know about mustard gas? Now we are going to speak about it. Alkylinating agent, they act at all phases of the cell cycle. So we have multiple medication. The most important one between all of these is the bisulfan. As always, why it's important? Because of the side effects. Which side effects is the most important? Pulmonary fibrosis. So far, 3 medications lead to pulmonary fibrosis. Bleomycin, methotrexate, and bisulfan. So all of the alkylinating agent do cross-linking of the DNA, except the last one, we don't even know how it works. So the bisulfonate cross-link the DNA, and this cross-linking, remember, it's not intercalating. Intercalating it's like putting a rod in between the strand of the DNA. While the cross-linking is like, okay, let me do both for you so you will understand how both of them. So if I just put like a piece of something in between the DNAs, which prevent normal like spreading of the strand, this is intercalating. But if I put like a connection between the same strand, but at different locations, so something like this, for example, or something like this is basically a cross-linking of DNA. So it's used to ablate patient bone marrow before bone marrow transplantation. Yes. So before you do bone marrow transplantation on somebody, to prevent the graft versus host reaction, you can do what? You can ablate the patient from all of his bone marrow by using bisulfan, and also by doing radiation of the patient. So it can lead to severe myelosuppression, and also in almost all cases, which is actually why we use it. And also can lead to pulmonary fibrosis and hyperpigmentation. Nitrogen mustard. So guys, maybe you heard about this World War II type of thing and this gas chamber, right? So the gas chambers, what they used to put from, like, you know, just for the sake of understanding what I'm speaking about. Yes, you know the gas chamber, like this showers thing, they used to put the people inside of them and then open the thing from up, and the person dies, right? So because of what? Because basically they used to use these guys, the mustard gas. So we have nitrogen mustards, cyclophosphamide and ifosfamide. We use them as a chemotherapeutic agent, but it's all about the dosage. So it cross-links the DNA, and it requires bioactivation by the liver. So it has a solid tumor. We can use it against solid tumor, leukemias, lymphomas, and autoimmune diseases. It can lead to myelosuppression, SIADH, Fanconi syndrome, hemorrhagic cystitis, and bladder cancer. Please know about the last two things. Cyclophosphamide can lead to bladder cancer and cystitis. On the USMLE, they would like you to know about cyclophosphamide and hemorrhagic cystitis, and that you can prevent it with Mesna. I'm repeating this question because it always comes on the exam. Cyclophosphamide lead to hemorrhagic cystitis, which can be prevented by Mesna. Okay, now this is the drug that was used by the Nazis. The mustine, basically lomustine and carmustine. It cross-links the DNA, requires bioactivation, and it can cross the blood-brain barrier, which means it can go to the CNS. It can be used in brain tumors like glioblastoma multiforme, Even if you use it, in case of a brain tumor, the patient is going to die within 1 year, because glioblastoma multiforme, basically it's the worst type of tumor you can get in your brain. And yeah, it has a CNS toxicity, obviously leading to convulsion, ataxia, and dizziness, and can lead to the death of the patient. Guys, do we have any gas chambers anymore? Is there any gas chambers in the world that this medication is used in? Sorry to surprise you, it exists. Do you know which country? I have no idea what is Switzerland, but it's in the US actually. It's in the US. It's in Arizona in the US. They use it to basically do capital punishment in people who choose to have it. Like, I cannot say it's the most humane way to kill someone. No, I'm against it. But anyway, I'm against killing anybody. But basically, like people who have death sentence can in the US, in some states like Arizona and Texas, you can choose the method of killing that you would like. Some people choose the gas chamber, which is this one. Some people use the lethal injection, which is, I think, they say it's the most humane. I don't think so. The other one that you can choose is basically the shooting squad. So there is multiple ways. Basically the person can choose how to die. You know, all of them sucks. So electrical chair, but not used anymore. Okay, guys, do you think after this mustard gas thing, the patient is going to die quickly, or he's going to suffer from half an hour till 2 hours until he dies? It's really slow, really slow acting. When they put the patient inside one of these chambers, it takes like only one person did it in the previous 10 years, and he took him 2 hours till he died. That's a bad idea, but don't worry, they put the curtains down so you don't have to see it. So the next one is a brocarbazine. The mechanism is unknown, weak monoamine oxidase inhibitor. So anyway, it can be used for brain tumors or Hodgkin's lymphoma. We don't know the mechanism, so don't worry about it. The most important thing to know about this is like the brocarbazine, that it has a disulfiram-like reaction. Anybody know which antibiotic has a disulfiram-like reaction? An antibiotic. Come on, antibiotic with disulfiram-like reaction. That was metronidazole. Metronidazole, yes. So in metronidazole, that has a disulfiram-like reaction because of the accumulation of the acetaldehyde, which lead to a hangover-like symptoms. Platinum combinant, all of this platine. I want you to think like this platines, you just really have to know that it's nephro and ototoxic. This is the only thing you have to know about. It also works by cross-linking the DNA. It's cell cycle non-specific for lymphoma and solid tumors. It's nephrotoxic, and remember when I told you, any drug that is nephrotoxic is also ototoxic. However, for platinum, you can prevent the toxicity by imifostine. Can bring Emi, the lady who wears a lot of platinum, to prevent the nephrotoxicity. Okay, let's speak about the microtubule inhibitor, which work at the M phase of the cell cycle. Basically, you know, at the M phase, we have the separation of the cells, right? And the separation will be impossible if you cannot like move the chromosome to the edges, which require basically microtubules to do so. So we have the taxans, so we have the taxials, and these guys hyperstabilizes polymerized microtubule, which basically prevent mitotic spindles from breaking down, which basically prevent them from moving if they cannot break down. Because remember, we form them, we boil a little bit, then we break them down. We form a new one, and like this. So if you cannot break them down, you are stuck, okay? So if you are stuck, that means that there is no proliferation. So we can use them for tumors, various tumors, like solid tumors, but they can lead to neuropathy and hypersensitivity. They love the neuropathy for these ones. Also for vinca alkaloid, we have the vincristine and vinblastine. They bind to the B-tubulin, which inhibit the polymerization into microtubules, so it prevents the formation of microtubules. So I remember the mnemonic taxis stabilizes satiety, which is why taxans hyperstabilize the polymerized microtubules, while the vinca alkaloid lead to inhibition of the polymerization into microtubules, which prevent mitotic spindle from forming. So we have vincristine and vinblastine. So solid tumors, leukemias, Hodgkin's and non-Hodgkin's lymphoma. So vincristine, neurotoxicity, these patients are going to have axonal neuropathy, and also they can have constipation, including ileus. Ileus basically means like there is a chronic constipation and absence of peristalsis. Okay, why? Because they have really bad neurotoxicity. Vinblastine can lead to myelosuppression. So that blasts your bone marrow, and vincristine, it crisps the nerve. Or I just remember a lady named Christine sitting in a wheelchair. And that reminds me that vincristine, these patients will have really bad neurotoxicity. Okay, so the next thing is about topoisomerase inhibitor. The topoisomerase inhibitor all causes DNA degradation, resulting in a cell cycle arrest in the S phase and the G2 phase. So these include irinotecan, topotecan. So the tecan is, TIC1 basically, TIC1. Inhibit topoisomerase type 1. They can be used in colon, ovary, small cell lung cancer, and they lead to myelosuppression and alopecia. And how many sides do we have? We have the right side and the left side. So they are for topoisomerase type 2. They also can be used for solid tumors and also can lead to myelosuppression and alopecia. Keep in mind that they work at the S phase and the G2 phase. This is what is important from you to know. You should not know the names of the tumors. You should know the side effects. You should know the mechanism of action. Tamoxifen is a selective estrogen receptor modulator with a complex mode of action. It's quite tricky actually, this drug. It works as an antagonist and a partial agonist at the same time. So it works as an antagonist in the breast, which is going to reduce the breast tumor. But it works as a partial agonist at the endometrium, at the bone. At the bone, it's good because it prevents osteoporosis. But in the endometrium, it can promote to endometrial cancer. So it blocks the binding of estrogen on the estrogen-positive cells in the breast. But in the endometrium, it's going to increase the lead to endometrial hyperplasia and even endometrial cancer. So they write, it's used to prevent and treat breast cancer. This one actually you have to know the clinical use. And the prevention in gynecomastia in people undergoing prostate cancer therapy, which requires actually sometimes medication that increase the estrogen. So adverse effect is hot flashes because of the partial agonist activity, and more risk of thromboembolic state like DVTs and VEs, and also it can lead to endometrial cancer. So the next thing we are going to speak about is going to be the anti-cancer monoclonal antibody. They work against extracellular target to neutralize them and or to promote immune system recognition. So there are so many of these guys. I will just tick next to the one that is really important, and I will just read super quick the one that are not important. So we have almituzumab. It's a CD52 monoclonal antibody. It's a we use it in CLL and multiple myeloma. They increase the risk of infection and autoimmunity. Like in case of ITB, we can use it. Okay. So, the bevacizumab, this is important one. This is one of the ones that, this you have to know. Also this. Okay. So let's see. So it's a VEGF monoclonal antibody, which basically going to prevent the formation of blood vessels. I know that you can see a lot of cancers here, but actually it's irrelevant to all of these cancers. The question comes about the angioproliferative retinopathy. Patient who has a retinopathy, in case of diabetes mellitus, can have an angioproliferative retinopathy and an non-angioproliferative retinopathy. If it was an angioproliferative neuropathy, it's basically a lot of vessels are forming inside of the retina, and for the sake of preventing this, you can use the bevacizumab inside of the eye. You inject it directly inside of the eye to prevent this from happening. Side effects include hemorrhage, blood clots, and impaired wound healing. Cetuximab and bantumumab is an EGFR inhibitor, which is epithelial growth factor receptor inhibitor. It can be used for metastatic colorectal cancer and head and neck cancer. It can lead to rash, high LFTs, and diarrhea. Rituximab is super important, however. The previous one, not really, but this one, the rituximab, is super important. CD20, which means it works at the B cells. All of these diseases are B cell mediated. Non-Hodgkin's lymphoma, the B cell one, the CLL has B cells, rheumatoid arthritis, antibody by B cells, ITB, TTB, and autoimmune hemolytic anemia. Both of them has antibody mediated which come from B cells. And multiple sclerosis. Basically, everything that is antibody mediated can be inhibited by rituximab. Increased risk of BML, because which is a progressive multifocal leukoencephalopathy, which is a demyelination disease that demyelinate the whole CNS, which is caused by the GC virus. All of us has GC virus, but it is inactive. This one is high yield, the trastuzumab. It works at the hair too. Remember, I told you, trust her, because she has breast. So it's used for breast and gastric cancer. It can lead to dilated cardiomyopathy. This is super high yield, but this one is reversible. The question comes as follows. A patient was started on a trastuzumab because she has a breast cancer. Which of the following tests you should do for her? Answer number one, answer number one, echo. Answer number two, ECG. Answer number three, Holter testing. Answer number four, I don't know, fecal occult blood testing. The correct answer is going to be echocardiography to check for dilated cardiomyopathy. Okay? So at trastuzumab, you should always do echocardiography regularly. Okay, so the next treatment, we spoke about them before. If you don't know what these are, please revise the pathology, the neoplasia chapter where we spoke about them. Remember the programmed death receptor number 1 and its ligand? There was some antibody against them that used to inhibit them, and the main task for us was to activate the T cell to be able to kill the tumor cells, right? So also we have the ipilimumab that works at the CTLA4, which also helped in activation of the T cells, which helped in the killing of the tumor cells. So it can be used for multiple tumors, most importantly renal cell carcinoma, where it is, yes, here it is. And increased risk of autoimmunity, enterocolitis, hepatitis, pneumonitis, and endocrinopathy. Why these agents are important? Because the guy won a Nobel Prize in 2018 for them. So I'm going just to go and show you them really quick. So as you can see here, we have the immune checkpoint interaction. You can see the monoclonal antibody against the CTLA4. So if that is inhibited, the B7 from antigen presenting cells is going to bind to the CD24, which lead to activation of the T cell, which is going to kill the tumor cells. Also, you can see inhibition of any of these by antibody to any of these is going to basically prevent the inhibition of the T cell activation. So an inhibition of these will lead to what? More T cell activation, which also kills the tumor cells. So let me go back here. Okay, so the next thing I'm going to speak about, let me take a look. Okay guys, I think this is enough for here. We have just like a couple of pages left. We'll deal with them tomorrow. First thing, be done with the hematology, and I'm going to open like a pool. I want your help. I just want to know which system I should need to know to do next. Should I do metabolism, which I highly suggest that you go for it, or should I go for MSK? It's up to you. Open the pool today and you will decide. So see you guys tomorrow.